Hello, everyone. It's Dr. Jensen from Dean's Chat. If you're on the fence as to whether you want to join the American Podiatric Medical Association, jump on in. It's a new APMA. Whether it's advocacy concerns, scope of practice, billing and coding, consider membership at the APMA as your professional insurance. Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine and surgery. My name is Dr. Jeffrey Jensen, the Dean at the Arizona College of Podiatric Medicine, and usually the co-host for the Dean's Chat podcast. But today I'm running solo. So Dr. Ritchie's on vacation, but we're not going to have any shortage of things to talk about. I'd like to welcome Dr. Steve Kominsky to Dean's Chat.
Thank you so much. It's a pleasure to be here. It's great to see you.
It's great to see you also. Dr. Kominsky, we're very informal on Dean's Chat. Is it okay if we go to Steve and Jeff?
Sure, absolutely. Please do.
All right. Well, thank you. So it's an absolute honor and a privilege to have you on, Steve. I have your book that I had in my bag for years, The Medical and Surgical Management of the Diabetic Foot. And I was going through it yesterday, kind of, preparing for our lecture. It's amazing how, while things change, some things don't change. Debridement, offloading. We see so many cool advances in antibiotics and reperfusion and things. But gosh, a lot of the tenets for wound healing stay the same. So we got a whole lot to talk about your career. So the audience knows, I was a resident at Kern Hospital in like 93. And I went to visit you in DC to see how your clinic ran. And I remember when I was with you, we applied a whole bunch of total contact casts, and it just left an indelible mark on me and really had an imprint on my career. So I want to thank you for that before we get started.
No, don't be silly. It's my pleasure.
That's fabulous. So, Steve, one of the long-standing great residencies in our profession is MedStar. And you were the founder of that program down over at Georgetown.
So, yeah, I was the founder and the program director for the first 25 years. When I started that program, we started with 2 residents. When I resigned from the program, we had 16.
That's amazing.
Yeah, the group crazy.
I think Dr. Steinberg, who's the director now, is it possible he has 8 residents per year? It might be.
Yes. I believe that there are 24 residents in the program now.
Right. Incredible program. What a legacy for you. But I wanted to go backwards a little bit, Steve, if that's okay.
Sure.
I'd like to talk about when you first got into podiatric medicine. The profession wasn't what it is today. That's certainly true. It wasn't when I got out either. There was a limitation on numbers of surgical residencies, not as many educational opportunities. It was just a different world.
So, yeah, clearly, when I graduated from school, there were not enough residency spots for every graduate. And I mean, it was very, very competitive. It was very, very difficult to get a spot. It was very stressful, to say the least. I thinking back in retrospect, I can't imagine spending whatever we spent on tuition, graduating, and then not getting a residency program after that. I can't imagine the stress and the anxiety that would have caused. The other thing that has changed dramatically is that back when I graduated, there was no Casper, so that we had to travel to every residency program to interview. And if you were lucky enough to get a second interview or a callback, you had to go back to that program again. So we were flying all over the country all the time. It was very costly.
No doubt. So when were you, I'll start kind of like with the end and we'll come back. You're currently working in the Phoenix area with the Advanced Spine and Orthopedic Partners providing foot and ankle care. So we'll touch on that in a little bit. So you're still active in the profession. You're going to be taking students from our college starting in January in their 3rd year. So I just wanted to give that little preface also. Coming back though, when you were growing up, had you even heard of podiatry or how did that work for you?
No, I didn't know anything about podiatry until I was in college. I went to University of Maryland. I was living in a fraternity house because I couldn't get into a dorm. And one of my fraternity brothers, who was a pre-law major, happened to get a catalog from PCPM. And he said, I don't want this. I was a biology major in college. thinking I was going to go into medical school. And he said, "Do you want to look at this? Otherwise, I'm going to throw it away." And I said, "Sure, let me take a look at it." I looked at it. It seemed pretty interesting to me. So I reached out to a podiatrist in the community out where University of Maryland was in Rockville, Maryland. I went to his office, met with him, watched him do a couple things in the office, and I thought that was pretty cool. And so my first break from college, I went to visit PCPM, and from there it was like it was a marriage for me.
My gosh, that's great. Because I remember, Steve, when I went to podiatry school, it was late 80s. The Pennsylvania College and the California College were considered like the top two schools.
Right.
Was that the same when you were? It was just not far beyond.
Yeah, I mean there were the five schools back then,
Yeah.
and absolutely Philly and San Francisco at the time were the two best by far, and then the others kind of fell into place after that.
Oh, how interesting. So when you shadowed this doc, uh, how many shadowing experiences or how much time did you spend with him before you said, "Hey, this is for me"?
I think I went to visit him in his office twice, and then but what I found out was, as it turns out, my grandmother had a podiatrist, who
Oh,
was basically a chiropodist back then. And I went and spent a day or two in his office watching what he did, and I was hooked at that point. I knew that I wanted to pursue that career, but I didn't want to be the guy on the corner. That's always the reference that I had because my other grandmother, who lived in Northeast Philadelphia and lived in a row house, the end row house in her on her block was a podiatrist who had an office in his basement,
oh my.
and I didn't want to be that guy. I wanted to do more with my career and my profession, but those were sort of my guiding lights at that time.
Oh, that's great. So you
Yeah.
went to the Pennsylvania College, and then your career kind of had these two arms. One was surgical, and one was diabetic feet, and they were both. You were very intense in both areas, a leader in both areas. Which came first? I imagine it's surgery, then diabetes, and diabetes care. But how did that play out for you? Because you were way ahead of your time.
Yeah, well, thank you. When I right after I finished my residency program, I went down to Carville, Louisiana,
Oh, I
and
was going to ask you. Yes.
I spent 4 months with Paul Brandt and Bill Coleman, who was his podiatrist working there at back then, and that really opened my eyes to diabetes, the neuropathic foot, and the complications associated. Then that's really where I learned about contact casting. And then I took that back to DC and sort of combined that with my surgical training and started doing all kinds of Charcot reconstructions and, you know, resections and it just they kind of grew together.
Oh, that makes sense. So I got to know Paul Brand pretty well in the late 90s, early 2000s. And he was already retired. And John Boswick gave me his number actually, because I was working on an NIH grant.
Yeah,
And what a gentleman, what a scholar, just an incredible
yeah.
man. Your recollections of Dr. Brand.
He was an amazing guy. I mean, he was very, very bright. He was very quiet, very calm. I mean, just an awesome guy. He wrote the forward in my textbook.
I know, I was just reading it yesterday. It's
Yeah,
right here. Oh
yeah,
my gosh, he's incredible. And when I was having lunch with Dr. John Boswick, he's passed away now, but the Boswick burn meetings in Maui still. And
sure.
John and I used to compare notes on current clinical trials and research and everything that was going on in the diabetic foot space. And he's
Yeah,
the one who introduced me to Paul. And so he gave me Paul's number and he said, just call Paul, tell him I sent you. I'm like,
yeah.
really? And it's literally, I went to my office, closed the door, dialed the number, and Paul Brand answered the phone.
It's a phone, right? That's the kind of guy he was. He didn't have a big staff. He didn't. I mean, he took care of patients and lived a very simple life. But he was brilliant.
Absolutely brilliant. And I think it was kind of cool that Philip Yancey brought his life to the textbooks and Pain the Gift Nobody Wants, all those great books.
Sure,
Um,
sure.
so it's kind of funny because Paul's so brilliant and Philip helped put his name out in front of everybody, whether it was a religious context or a medical
Right,
context.
right.
All right. So you went back to Philly and was it hard to start a diabetic foot clinic or were you these patients there and you didn't know it? I mean, how did that play out?
That's a fascinating story. So I'm never shy when it comes to talking with physicians and wanting to build a practice and grow a practice. And of course, that I had two partners in DC, Jeff and Stu,
Okay.
and I kind of brought the concept of the diabetic foot, the neuropathic foot, back to them. And there was no, I mean, back then, no. I've told the story many times that when we would go to a podiatry conference, maybe on occasion, there was a lecture, in a 3-day conference, maybe a lecture on the diabetic foot or neuropathy. But there was certainly never a whole section or a whole conference. There was no textbook on it back then. I mean, nobody knew anything about the diabetic foot. And so I saw an incredible opportunity in DC, being a city with the demographics that they have there. I thought this is going to be great for me. And I talked to Jeff and Stu about it, and they said, we want you to run with this, see how far you can take it. And so I started giving local talks around DC. I started going, I went to some churches in the city, met with the congregation, and it grew very, very quickly. And I mean, this is long before the wound center at Georgetown didn't exist back then. I became kind of the go-to dump guy in DC for all the diabetic problems that nobody wanted to take care of.
Wow. And back then, people weren't talking about quality of life or,
Oh, no,
saving money by healing them instead of going
no,
through a series of infections and admission, things like that.
no. Back in those days, it was amputate so that the physician or surgeon didn't have to deal with the problem. I mean, there are 1,000 stories that I could tell where legs or feet just got cut off because it was easier than managing the problem.
Oh my gosh, you're right. Um, that's so fascinating because when I was a resident, um, between you and Jeff Treadwell and Stuart, you brought the diabetic protocols to the current hospital in Detroit,
Right, right.
and it was an eye opener for everybody because I'll never forget I was there as a clerk, and there was this Diabetic Foot Centers of America clinic, and everything was protocoled. And back in those days, Steve, I mean, maybe I was living in a bubble, but there weren't protocols for things back then.
No, it was like the Wild West. I mean, no. I mean, first of all, nobody knew anything about it. Second of all, there were certainly no regulations or guidelines back then, and so we kind of wrote the book, no pun intended, on that arena, if you will, that patient population, and it was really pretty. It was pretty incredible. It was a lot of fun. It really it helped me get to where I am now.
Absolutely. Well, what's so funny about that, Steve, is now it seems so self-evident. You have podiatrists, vascular docs, ID, endo, podorthist on staff. It seems
Sure.
so matter of fact today, but that was not the norm back then, to your point.
No, not even close. I mean, we no. I mean, I used to do probably 25 total contact casts a week. We had a full time pedorthist in our office. I mean, we were doing things that it was unheard of back then.
Absolutely. It's funny because I brought that total contact casting to my practice in Denver, and nobody did it in Denver. In fact,
Right,
people are like, "Oh, what's going on here exactly? Why are you covering up that foot ulcer?" For
right,
a period of time. But it's so fascinating because we're still quoting Paul Brand saying it's not what you put on the wound, it's what you take off the wound.
and all the time. I use that expression all the time.
Oh, I
Yeah,
remember you all taught it to me. I
right.
mean, but but it standed the test of time, right? Because nowadays, when we talk about advanced products, I just say, the goal of the advanced products is to shorten the proliferative phase of wound healing. It's a something else, not necessarily requirement, and
Right.
that's kind of met with a jaundiced eye once.
Absolutely. I mean, it's big pharma, if you will, has really taken over that arena. Back in those days, we didn't have all the skin substitutes. We had nothing. We had porcine grafts. That was about the extent of it. But the reality of it is, we didn't need all these skin substitutes back then. The vast majority of those feet healed with good care. I mean, that's really all they needed, offloading and good care.
It's interesting because I've seen patients do well, like your dialysis patients or your transplant patients. They're just a little harder to heal, right? Or a patient that's peripheral vascular disease that they've already done bypasses. And we've pretty much run the gamut. But for your typical wound that walks in the door and there's good blood supply and no infection, the protocols are pretty straightforward nowadays.
Yeah. I could say, and I've said many times, a monkey could heal an ulcer. Honestly, 9 out of 10 times, if you just understand the biomechanics of it. And I've talked to my residents a lot about this as well. I remember when I was in school, I hated biomechanics. I didn't understand it. I thought, I'll never use this. I don't need this in surgery. And lo and behold, I use biomechanics every single day. And they apply to the diabetic foot top to bottom. I mean, if you understand the mechanics of gait, then you can heal anything.
You can also predict where the wounds are going to occur.
Oh, absolutely correct. It's a roadmap on the bottom of the foot.
So let me ask you this question. I always thought that everybody used a dermatemp or skin thermometer on feet, diabetic feet, but I come to realize that was very unique back in the early 90s.
Right.
That was not protocol. That was not well known. How did you all come up with that and to actually quantify it?
So, I remember I could visualize the infrared thermometer that we used to have and use in the office. I remember reading an article about thermography and, heat emission from inflamed areas, sore muscle, tendinitis. And I thought, you know what? Repetitive stress creates an ulcer. There's inflammation. Excuse me. There's inflammation there, of course. Why don't we start measuring that and quantifying that? And perhaps we can publish that as well, et cetera. And it just kind of evolved from there.
Wow. And there have been all kinds of renditions on how to get those temperatures and how to capture them and how to implement care in a high-risk patient.
Right.
Pretty incredible.
So, along with the infrared thermometer, don't forget about the Weinstein.
For sure.
Nobody even knew what they were back in the 80s. And somehow, I don't remember how, to be honest with you. I fell upon Weinstein probes and made that a part of every diabetic foot exam. And that was cutting edge back then. Now it's, everybody in the world has them.
That's right. A funny story, Steve. When I moved to Denver, I bought like 500 Weinstein monofilament wires, and I sent it to all the primary carers and said, "Hey, if your patients can't feel this, send them our way."
That was a great idea.
Worked great. It was the only way we could. As you know, a tuning fork is so subjective, right?
Yeah, no, I was never a fan of the tuning fork.
Right, and then deep tendon reflexes are a shot in the dark too.
Right, I agree. For me, it all boiled down to Weinstein. If they could not feel the 5.07 probe, they were neuropathic.
Fact. It was so fun because you could actually show them at what level they were neuropathic.
Yeah. Right.
Yeah, those were good days. Now, sometimes I wonder if Weinstein monofilament wires are even used routinely. I'm not sure.
I can't speak to that. I'm not really sure. I certainly don't hear about them when I go to a conference or I speak with a fellow colleague somewhere. Nobody talks about them anymore,
unless they're just part of protocols. But I'm not sensing that they are.
Yeah, I agree. I agree with you.
Dean's Chat is headed to the National in Nashville in just a couple months. Jeff, are you excited?
Oh, I'm very excited. We'll be there on August 7th. We'll be at the APMA National Meeting. It's kind of the pod expo we'll be involved with. Hopefully, if you're there, you'll come by and say hi to us.
Yeah, last year was so much fun. It was we had some scheduled interviews. We had people walk up and be part of the community. And it's wonderful to connect with people in that organic and natural way there in the expo hall.
Absolutely. It's always fun to catch up with our colleagues. And last year, I thought it was one of the highlights of the meeting. So I'm really looking forward to it. So if you have not registered yet, go to www.apma.org/the national. And we encourage you to be there and hope you can drop by. And we'll even do a little interview if you want and put you on Dean's Chat.
Yeah. The fun little snippets. We love to, but even if you don't want to be on and you just want to come say hi, we love to engage with the audience and connect.
Absolutely. Bye now.
Cheers, everyone.
A couple other things I wanted to talk to you about, and this is just kind of like trip down memory lane. Vascular assessments, calcified vessels, the digital, the hallux pressure being, it's not subject to the calcification to the same extent. How we could get toe pressures, and they were so predictive. Your thoughts on all that, and where a lot of that came from?
So as we were ramping up Diabetic Foot Centers of America, we had the fortune of partnering with chief of vascular. Well, he was chief of vascular surgery at the VA in DC back at the time. A guy by the name of Tony Sadawi. And as we started to travel around and do lectures, and I will around the country, Tony would go along with me, and he'd give the vascular talks. And he had done a lot of research on lower extremity vascular disease, and he trained at Harvard with a guy by the name of Frank Lagerfo,
For sure.
who actually wrote a chapter in my book as well. And what their research showed was that, in fact, the diabetic extremity actually revascularized distal to the knee. And that was the whole evolution of the distal bypass, which has now become endovascular reconstruction. But as the distal bypass was progressing and becoming mainstream in the late 80s and into the 90s, we realized that toe pressures were great. In the majority of patients with diabetes, they had excellent, very distal blood flow. Where they were clotting off was in the more proximal vessel. And so that's why the distal bypass was so successful and so effective. And that's kind of how it evolved.
That's great. I remember when the vascular surgeons at our hospitals in Denver were doing the distal bypasses, they would refer to the FEMPOP as a head of steam bypass.
Right. Exactly. Right. How old school was that, right?
Totally.
But that's medicine. I mean, we learn by advancing, and we have the naysayers, and then we have the people who don't listen to the naysayers and keep pushing ahead. And that's how medicine advances, honestly.
No, that's so true. I have a question for you, because what I'm sensing is healing patients is becoming more routine, right? But we're still struggling with recidivism, right? And wounds returning, lack of adherence with wearing the appropriate shoes and insoles. And I don't blame them. I mean, I used to have patients tell me, "I'll wear these shoes when you wear these shoes," kind of thing, right? You know what I mean? I mean, it's a struggle. So there's more and more emphasis on prophylactic surgeries, continuing to wear appropriate shoes. What do you see long term for decreasing recurrence in the diabetic foot?
I don't know that that's going to change much, to be honest with you. I think that a lot of that is patient education at the physician office level, and I don't think that's being done. I don't see it being done. I've asked many patients and had many conversations with physicians, whether they have diabetes nurse educators or access to nurse educators. Do they have, do they send their diabetic patients to education classes? And the answer is invariably no. And so I think until that, or if that were to happen, maybe what you're talking about would change. But otherwise, the only way is really with prophylactic surgery. And that's hit or miss in terms of whether the patient has the surgery, whether the physician okays it. I mean, there's still those odds, those hurdles.
There's no doubt. And I often wonder, Steve, we have at any given time between 1,500 and 2,000 wound care centers in this country. I don't, it's in their protocols to take a patient from A to Z in terms of healing, but I don't think it's in their protocols to take it that next step and prevent wounds from recurring.
I always felt that was the role of the podiatrist, quite frankly.
Oh, refer back or refer out?
Well, for us to educate the patient. If I had a patient in front of me with an ulcer and I was lucky enough to get that ulcer closed, I had long conversations with the patient and educated the patient on recidivism, recurring breakdown, how to avoid it, what to look for at home, how to self-examine at home every single day, and the importance of doing it every single day. And certainly some of them did it and adhered to it. And of course, obviously, a large percentage did not. And those are the ones that come back a year or two or three later with either the identical problem or a different problem on the same foot. I mean, that's just the nature of that disease, quite frankly.
That makes sense. No, and I agree with you. Until we find a cure for diabetes, we're going to have neuropathy at high
No.
levels. So
How about all the patients that don't have diabetes but still have neuropathy?
that too.
I mean, neuropathy, I'm in the practice that I'm in right now. I see more patients with neuropathy that don't have diabetes than do have diabetes.
Really? What are the origins?
Idiopathic,
Yep.
or oftentimes spinal cord pathology. Either radiculopathy or something like that.
Well, and then there's alcohol component too. It's funny, Steve, because all of a sudden I'm remembering all these stats from the old days. Didn't it used to be that 8% of our patients had idiopathic, or of those that are neuropathic, had idiopathic neuropathy?
Yes.
Something like that,
Yeah.
right?
Yes.
That's a big percentage.
It was 11%.
Okay.
And NIH, for years, NIH was doing studies on idiopathic neuropathy, trying to get a handle on it. I honestly don't know what the outcome was. I think they just abandoned the studies after many years because it's such a large patient population that they just had no answers for.
That makes sense. I had a good friend who had lots of chemotherapy with cancer, and chemotherapy meds create neuropathy.
All the time. All the time.
So there's just all these little buckets of patient populations with neuropathy that potentially all the same end result.
Right, exactly right.
Wow.
Well, and you mentioned Paul Brand. When I first went down there and started, basically he was treating Hansen's disease.
Right.
He's the person who made the leap from Hansen's to diabetes. So, yep. We certainly didn't know a lot about it back then. And I'm not sure we know a whole lot more about it now.
Well, that's fair. It's incredible. It's quite a science, and we simplify it to the, kind of sift out the most important variables. I don't think we've written the full book on it yet, but we sure have got a handle on the mechanics and depth of wound and vascular things like that. All right, Steve, I'd love picking your brain, but let's shift gears a little bit and let's talk. I've found that doing these interviews on Dean's Chat, so much of the fun is talking about the person behind the article or the textbook. And so what makes you tick? You recently moved to Arizona. I know all your professional passions are from what do you do to recharge your battery?
That's a great question. I'm still trying to figure that out. For quite a while, when I was still back east, I was cycling. I had a bad bike accident that kind of took me literally off the bike for a while. I used to play tennis. I've got a shoulder replacement now. I think fishing is probably my vice at this point. I have found a great area in Arizona to go fishing, fly fishing for trout and so forth. I found an Apache reservation up in Greer in the White Mountains that I've been fishing, and it's a blast. However, I just signed up for the Gold Farm meeting, which is in September in Montana.
Ooh.
That's a 4-day boondoggle for fly fishing and lectures.
Oh, yeah.
Yeah.
Montana's a hot spot for fly fishing. I grew up in the Midwest, so we were doing more lake fishing, like walleyes, northern, stuff like that. And then when I took up fly fishing, my kids were little, and I was afraid they were going to fall in the stream. So I never fully got into fly fishing. But I've got friends that when they're not fishing, they're making flies to match the hatch in their garage.
Yeah, I don't know that I have the drive to make my own flies. I think at this stage, at this age, but certainly to get out there on the water is heaven for me.
Oh, that's fabulous. I've always been impressed with your leadership and your advocacy for the profession. I know that when we started a residency in North Colorado, the residents they're like your kids, right? I mean, you're helping them through that process. You were 25 years, right? The program
Yes,
director.
yes.
What was that like over the years, mentoring these young kids and then watching them turn into, at the lecture at ECFAS or something, giving it?
It has been the greatest thrill in my professional career. I still get calls and text messages and emails from residents, former residents, all the time with X-rays and MRIs seeking my opinion on a case, or them showing off to me how they got this great trauma and they were able to put the ankle back together or whatever it was. And I'm so proud of being a part of their education, and they're all doing great, and it's an incredible thrill for me.
That's such a, career perspective. Residency training is such a small period of time, but has the largest impact
Oh,
on your future.
no question about it. I had to reach out a couple of years ago. Actually, when I applied for my Arizona license, I don't have my residency program certificate. Somewhere along the lines, I lost it, and the hospital has closed. But so I reached out to my residency director, who's still alive,
Oh my
and
gosh.
he's in his mid 80s now, and he sent a letter. He had it notarized. Talking about me as a resident and so forth. And then we spoke on the phone, and it was I hadn't spoken to him in probably 37 years. And it was just an incredible thrill for both of us to catch up. So you're right. It's a small period of time in life, but it's so meaningful.
That's awesome. I don't mind dropping names on the podcast. You've been a mentor to so many. Who were your mentors going through the process, Steve?
So probably the most notable, I guess, mentor for me, well, two. One was Richard J., who was a professor in Philadelphia, one very, very close, clearly was a mentor of mine. My residency director slash mentor was Steve Subotnick.
For sure. The running
Yeah,
foot doctor.
right, exactly. So I trained with Steve, and his partner back at that time was Barry Scurrin. And
Yes.
so
Oh, yes. From Kaiser.
I had some, right, exactly. I had some really, really good guys that I trained with.
Dr. Skurin, if I'm not mistaken, played with the Eagles at
He
one
did.
point.
He was their first drummer.
And so Don Henley supplanted him?
Yeah, I think that's right.
Oh, geez. Oh, that must have been an incredible training experience between Dr. Subotnick and Dr.
Well, the
Skurin.
names go on. So do you remember the name Nick Grumbine?
Oh, for sure. Oh, yeah. When he would make kids carve a talus out of a piece of soap in his interviews.
So we did a surgery one time on Subotnick's daughter. We did bilateral flat foot reconstruction at the same time. Grumbine was in Southern California. I trained in the East Bay, Northern California, and he flew up to operate, I guess, as a guest surgeon. Back then, you could do that.
Yeah.
And he came in. We did talar neck osteotomies on her,
Wow.
like closing wedge osteotomies to basically realign the hind foot. And so, what that taught me, cases like that, Bill Walton was a patient. We operated on him twice. It taught me anatomy. It taught me not to be afraid. It opened my eyes to how to realign things, and how things, sort of the hind foot impacted the midfoot, and it was great. So I had some very, very good mentors and program directors when I was training.
Well, that's incredible. Even before I thought about being a podiatrist, I had Dr. Subotnick's The Running Foot Doctor book, where he was leaning on
Yes,
the letters.
right,
And I thought that, George Sheehan, you remember the
of
running
course,
radiologist, he
right.
credited podiatrists with so much sports medicine advancement for the running community. Between Dr. Sheehan and Dr. Subotnick, maybe Dr. Levac, there were some real leaders there.
Harry Levac, yeah, for sure. Now that was a great time for the evolution of podiatry, and for foot and ankle surgery.
Absolutely. So you've had some sports medicine background then too.
I have a lot of sports medicine background. I was the team podiatrist of the Washington Capitals for 12 seasons.
Wow. What was that like?
That was a pretty cool experience. I'm a hockey fan anyway. My son played hockey for years, and when I had that opportunity and when I was asked to become a part of the medical staff, it was great. And so the players would come to my office. They'd hang out in the waiting room. I would treat them, take care of them, their sibling or their spouses, and it was awesome. I mean, I had a great seat at the arena. Got to see a lot of games. Spent a lot of time in the locker room, and I've been very, very blessed in my career.
Oh my gosh, that is just fabulous. Um, what else would you like to talk about, Steve? I mean, we could sit here all day and keep going. Um, how about currently? In Arizona, we're so excited to have you be part of the Arizona College and help train our students. Just remember, they're third years; they're not well versed yet. It's our job to train them up.
I'll have to back off a little bit. Yeah, but that's okay. That's all right. I'm excited to have them with me. I can't wait. In fact, I'm really looking forward to it.
Oh, they're sharp. They're so sharp. And, and I always talk about the medical school curriculum is nothing ever gets pared away. Things just get piled on, right? So the education they have in biomechanics and surgery and medicine, not to mention the proliferation of basic science knowledge that they're required to learn. It's a different educational environment than when we went to school.
It's interesting. I don't know if I agree with that completely. I mean, I think back to my 4 years in Philly. It was tough. It was really hard. And we had all the basic sciences. We had the surgical courses. Then we had the clinics. It was pretty comprehensive. I can't imagine that it's a lot. There's a lot more than that now. What I don't want is for the students to be coddled. That I don't want. I have a very strong. I don't want to talk about it now because I don't want to come off as negative. I have very strong feelings about the younger folks these days.
Yeah, it's a different generation. They're incredibly bright. I mean, they've had access to so much, right? They've traveled the world. They come in and they speak 3 languages. And they're well-rounded compared to me when I was coming out. That's for sure. But what I find is interesting, Steve, is even with an increase band of things that are required for them to learn, technologies and different learning techniques make such a difference, like those Anki decks and Notebook LM and all these things that make questions. And it's a different world, though. I mean, it's a world that you and I would have a tough time adapting to, I think.
When I was in school, there was no such thing as a computer.
Right.
Or a cell phone. So I mean, seriously.
Right.
So we actually had to we either listened to a tape from the note taker or we had to actually truly go to class.
Yep.
And we didn't spend any time on our cell phones Googling things or just chat GPTing things. I mean, so it is a different world, certainly from the technology standpoint. I don't know that it's all that much better. I guess it's better in some respects.
But it's different.
I'm dating myself when I say that.
I'm sorry?
I'm dating myself when I say that.
Me too. But one of my standard interview questions is still, what have you done in your past that will tell me your eyes and your brain will control what your hands do? Some things don't change in a surgical profession.
That is true. That's a great question, actually.
Yeah. I mean, it's amazing, woodworking and, working on cars, playing musical instruments, all of these really neat things that these kids do. And maybe it's just we're more exposed to it because we ask them questions and we do interviews like you and I are talking now. I mean, we interview students from all over the country and we do it on Zoom. And then I will always invite them to Arizona, check out the campus. But it's so different than it was even just before COVID,
Right. No, I mean, I think back, you talking about interviewing, and I remember all the years that we would go to the crypts and interview for residents, and and it was a challenge, but I loved it. I loved meeting the students. I loved challenging the students, and then trying to select the ones that would be the best fit. That was exciting. I do miss that, I have to say.
Oh yeah, that's exciting times. That's why when you brought up Dr. Grumbine's name, nobody will ever forget going to one of his interviews and hands you a bar of soap and said, "Here, carve me a talus."
Right. Yeah, Carter Talis, exactly. He was a wild man. He was kind of like out of the same cloth that Harry Vogler was from.
For sure.
Very similar personality, great surgeon. They sucked the air out of the room when they came in.
Absolutely. Oh, that's fabulous. Well, Steve, I want to thank you. I mean, it's afternoon on a Monday. Thanks for opening up your schedule to come and chat me up on the podcast.
Jeff, it's my pleasure. It's great to see an old friend. I'm still going to hold you to lunch.
Absolutely.
And, let's get together and talk about podiatry, talk about surgery, and talk about the students.
Oh man, I look forward to it, Steve. So for our listeners and people watching, Dr. Kominsky's book was like the book. You and Dr. Freiberg had a book too, right? High Risk Foot and Diabetes. Those were like
Correct.
the two big time textbooks for our profession in diabetes care. Absolutely.
Right.
All right. Well, Steve, thanks again. And I look forward to getting together. I'm sure we'll be doing a part 2 in the next year or so once you start having our students rotate with you. I can't wait to get some feedback.
I would love to do that. I look forward to it.
All right. Sounds good. Well,
Thanks.
You're welcome, Steve. Thank you for joining me. To all of our listeners out there, if you're listening on Apple or Spotify, please give us a 5-star rating, and better yet, even leave a comment or two. And if you're watching on YouTube, by all means, become a subscriber. Joanna, who's usually with me, and I will continue to bring in leaders in podiatric medicine and surgery, like Dr. Kominsky today. It's an honor and a privilege to have you on Dean's Chat, Steve.
Thank you so much. The honor is mine. Thank you.
Also, I'm going to send you one of these Dean's Chat mugs to kind of get your day going.
That would be awesome. I would love to have that. I would drink out of that every day.
Oh, and in the evening, you can put anything in it.
Shh, I won't tell anyone.
All right. Sounds good. All right. Cheers, everybody. Bye-bye.